Hello coders! So today we are going to be talking about a couple of the chapters of ICD-10. We're starting with chapter 6, Diseases of the Nervous System, which is our G codes. So our G codes, again, this is going to be anything to deal with things like Alzheimer's, Parkinson's, other nerve disorders. We're also going to deal with issues of paralysis here, neurostimulators, pain. So our guidelines are kind of going to go all over the place, and then we'll look at some of these codes on ICD-10data.com. So the first thing that we need to keep in mind is dominant versus non-dominant side. So when it comes, as they tell us, to hemiplegia hemiparesis. So again, half paralysis and half lack of strength for the paresis part. So what happens is when someone has like a stroke or another event that has led to this hemiplegia hemiparesis, we want to know which parts of the body are being affected, right, left, up, down, arms, legs, etc. And we also want to know what the dominant side for the patient is, meaning what side do they normally write with. So when it doesn't say these are the guidelines, if it says it in the documentation, we are going to use what it says in the documentation. We should always go back and query the provider about this, always ask them if they know which side is the dominant side so that we don't have to worry about this. But these are the guidelines when they don't tell us. So codes from categories G8.1, hemiplegia and hemiparesis, and subcategories G8.3.1, monoplegia of lower limb, G8.3.2, monoplegia of upper limb, and G8.3.3, monoplegia unspecified, identify whether the dominant or non-dominant side is affected. Should the affected side be documented but not specified as dominant or non-dominant, the classification system does not indicate default code selection is as follows. So when they don't tell us, this is what we do. For ambidextrous patients, patients who can write with both hands, the default is dominant. If the left side is affected, the default is non-dominant. If the right side is affected, the default is dominant. Again, this is only if it is not documented and we cannot get the information from the provider. We always want to try to figure out this information before we code it. Okay, so keep that in mind as we're going through. So that's our first set. Second set of guidelines is about pain. So codes in category G8.9, pain not elsewhere classified, may be used in conjunctions with codes from other categories and chapters to provide more detail about acute or chronic pain and neoplasm-related pain unless otherwise indicated below. So again, this is going to help us describe whether it's acute or chronic. It's also going to help with things like neoplasm-related pain. So if the pain is not specified as acute or chronic, post-thoracotomy, post-procedural, or neoplasm related, do not assign a code from category G8.9. So if they just say low back pain, we're just going to code low back pain. If they say acute low back pain, then we can code the low back pain and the acute pain. Same thing with chronic, neoplasm related. Okay. A code from category G8.9 should not be assigned if the underlying definitive diagnosis is known, unless the reason for the encounter is pain control or management and not management of the underlying condition. Okay, so we have to be careful about what's causing the pain. So if we know what's causing the pain, we do not use G8.9, except for a couple of very specific circumstances we are going to see as we go down. So, when the admission or encounter is for a procedure aimed at treating the underlying condition, like a spinal fusion or a kyphoplasty, a code for the underlying condition, like the vertebral fracture or spinal stenosis, should be assigned as the principal diagnosis. No code from category G8.9 should be assigned because we're doing the procedure to fix the problem so the patient will not have pain. So again, if we're going to fix the problem causing the pain, no pain. But sometimes we're just managing the pain. We're not fixing the pain. So that's when we can use G8.9. Okay, so category G89 codes are acceptable as a principal diagnosis or first listed code when pain control or pain management is the reason for the encounter. So like the patient with a displaced intervertebral disc or nerve impingement and severe back pain presents for an injection of a steroid into the spinal canal. Again, the reason why they're going is for pain control and pain management. So the underlying cause of the pain should be reported as an additional diagnosis if known. So again, if a patient has a nerve impingement in their C5, okay, in their cervical spine around C5, what we're going to do is, if that's what's causing the pain, we code the pain code first, then we code for the underlying condition, what's causing the pain. Because again, we are not fixing the pain for the patient. We are treating the pain with pain control and pain management. So we want to kind of keep that in mind. Why is the patient there? We can also use it when the patient is admitted for the insertion of a neurostimulator for pain control. We assign the appropriate pain code as the principal or first listed diagnosis. When admission or encounter is for a procedure aimed at treating the underlying condition and a neurostimulator is inserted for pain control during the same admission or encounter, a code for the underlying condition should be assigned as the principal diagnosis, and the appropriate pain code should be assigned as the secondary diagnosis. So again, when they're coming in specifically for insertion of the neurostimulator, okay, pain code goes first. But if we're treating the underlying condition and then we also happen to place a neurostimulator, the reason for the surgery is to fix the condition. Condition would go first, then pain. So it's all situational. Why is the patient coming in? What are we doing for the patient during this session? Now it goes on to tell us, codes from category G89 may be used in conjunction with codes that identify the site of pain, including codes from Chapter 18, if the category G89 code provides additional information. For example, if the code describes the site of pain but does not fully describe whether the pain is acute or chronic, then both codes should be assigned. And we're going to look at the G89 codes in just a few minutes so you can see the difference between like a low back pain code and the actual G89 codes. Now again, the sequencing, we have to be careful. Sequencing, what order do these codes go in? The sequencing of category G89 codes with site-specific pain codes, including Chapter 18, is dependent on the circumstances of the encounter as follows. If the encounter is for pain control or pain management, assign the code from category G89 followed by the code identifying the specific site of pain. Example, encounter for pain management for acute neck pain from trauma is assigned code G89.11, acute pain due to trauma, followed by code M54.2, cervicalgia, to identify the site of pain. And again, that's for pain control and pain management, okay? However, if the encounter is for any other reason except pain control or pain management and a related definitive diagnosis has not been established or confirmed by the provider, assign the code for the specific site of pain first, followed by the appropriate code from category G89. So again, if they're going for pain control, pain management, pain code goes first, then the anatomic site of pain. If they're coming in for another reason, then site of pain goes first, then more specifically the type of pain, okay? So we have to keep this in mind. It's all situational. Now, pains due to implants and grafts, again, and postoperative pain, those are going to come mainly from other sections. However, postoperative pain does tell us the default for post-thoracotomy and other postoperative pain, not specified as acute or chronic, is coded for the acute form. So again, if this is after a surgery, if this is postoperative, they usually assign the pain code as acute unless otherwise stated. Now keep in mind, routine or expected postoperative pain immediately after surgery should not be coded. So for instance, when someone gets their gallbladder out, the surgeon tells them it's going to take about 7 days for you to feel back to normal. You're going to feel some discomfort after that point, but you shouldn't feel any pain. And it does take just about 7 days. So any of the pain the patient's feeling in general is routine and expected. But if the patient is in such extreme pain, they're uncontrollable, screaming and thrashing and things like that, then that's above and beyond, okay? Then they're going to look at, is that a complication? And if that is a complication, again, we have to be careful because most of those should be coded as a complication, not as acute or chronic pain, which it reminds us right here. Postoperative pain not associated with a specific postoperative complication is assigned to the appropriate postoperative pain code in category G89. So again, when it's not associated with a postoperative complication, okay? But if postoperative pain is associated with a specific postoperative complication, such as painful wire sutures, it is assigned to the appropriate codes found in Chapter 19, Injury, Poisonings, and Certain Other Consequences of External Causes. If appropriate, use additional codes from G89 to identify acute or chronic pain. So again, we have to be careful. Is it associated directly with a complication from their procedure, or is this something completely different? So for instance, if someone has their gallbladder out, that is in the upper right-hand quadrant, right below the liver, okay, or behind the liver, I should say. So if the patient's having pain in the upper left-hand quadrant after that procedure, that's something that's abnormal. We're going to look into that. We can code for that. But again, if they're having pain or discomfort in the area where they just had surgery, it's considered usual unless the doctor says otherwise. Now again, chronic pain is classified to subcategory G89.2, and there is no time frame defining when the pain becomes chronic pain. The provider's documentation should be used to guide the use of these codes. And you can look up online to try to find different regulations and standards for when pain becomes chronic. It really depends on what area of medicine you're in. In general, there are kind of average time frames that doctors use, but it's really up to their medical decision making to tell us whether the pain is acute or has become chronic. Now, code G89.3 is assigned to pain documented as being related, associated, or due to cancer, primary or secondary malignancy, or a tumor. This code is assigned regardless of whether the pain is acute or chronic. So remember, neoplasm is a new growth. So this could be, you know, a malignant cancer, or this could be like a lipoma, a large fatty tumor that's causing pain. Either way, it's a neoplasm, it's a new growth, it's going to fit under G89.3. Goes on to tell us, this code may be assigned as the principal or first listed code when the stated reason for the admission is documented as pain control or pain management. The underlying neoplasm should be reported as an additional diagnosis. So again, we don't forget the neoplasm code, just also can go first. Why? Because we're going in for pain control and pain management. Again, remember, what's the main reason for the encounter? The underlying, when the reason for the encounter is management of the neoplasm and the pain associated with the neoplasm is also documented, code G89.3 may be assigned as an additional diagnosis. It is not necessary to assign additional code for the site of the pain. So for neoplasm-related pain, we don't need to specify where the pain is in the body. But again, it's situational. So what's the reason for the patient's encounter is whether or not the pain code or the neoplasm code will go first. Now the last section of our G-code guidelines, central pain system, G89.0, and chronic pain syndrome are different than the term chronic pain and therefore should only be used when the provider has specifically documented this condition. Okay, so we're going to look at all of these. So let's start by looking at the breakdown of this section. Okay, so we're going to see inflammatory diseases, systemic atrophies, extrapyramidal movement disorders, degenerative diseases, demyelinating diseases, episodic and paroxysmal disorders, nerve root, and plexus disorders, polyneuropathies, myoneural junction muscle diseases, cerebral palsy, and other disorders. So let's start with the G8-9s so we can take a look at this. So G8-9 pain not elsewhere classifiable. Okay, so as we go down here, okay, so again, let's look at central pain syndrome. So central pain syndrome is its own code. It's different from acute or chronic. Sometimes this is also known as Dejerine-Roussy syndrome, myelopathic pain syndrome, or thalamic pain syndrome. Basically, this is a type of pain where they don't know a lot about it, but it's something that a patient does feel, and it feels different from regular acute or chronic pain. And so they put it in its own category as they're trying to learn more about it. So this is the central pain syndrome. Central, again, thalamic. So again, we're talking about it being more in the chest cavity. As we go back, we have chronic pain syndrome, G8-9.4, okay, and chronic pain syndrome, again, has a psychosocial dysfunction associated with it. So it's chronic pain with a psychosocial dysfunction, and this tends to come with, you know, other conditions that can create these types of problems. So again, think of problems like multiple sclerosis, fibromyalgia, where there is a psychosocial aspect to this because the pain does not allow the person to do what they want to do. In the other pain codes, we can see, again, G8-9.1, we have acute pain due to trauma, acute post-thoracotomy pain, and other acute post-procedural pain. For chronic pain, again, chronic pain due to trauma, chronic post-thoracotomy pain, other chronic post-procedural pain, and other chronic pain. And then G8-9.3 is neoplasm-related pain, acute or chronic. So again, for these, we just need to make sure we are picking out the proper pain code. Because again, we want to make sure that we are coding specifically for the acute pain, if we need it, the chronic pain, the neoplasm, the central pain, or the chronic pain syndrome. And so again, how does the doctor specify the patient's pain? If it's not specific enough, can we look in the record, and then can we query the provider? When it comes to the other sections here, again, we're going to see a whole variety of different codes. So for the inflammatory disorders, this is where we're going to see our meningitises, our encephalitises, our intracranial and intraspinal abscesses, okay? We're also, as we continue through, we get to the systemic atrophies, things like Huntington's disease, muscular atrophies, post-polio syndromes, where again, there's an atrophy of the system. So the system is not functioning properly. Remember, A means no, not, or without. Trophy is nourishment or development. We're also going to have a whole section on Parkinson's disease, secondary Parkinson's disease, dystonia, which is issues with muscle strength and movement, other movement disorders. Again, we're going to have a whole area of just Alzheimer's disease and other degenerative diseases. Then we have a whole issue of multiple sclerosis and other demyelinated disorders. Remember, the myelin is the covering on our nervous system. It's the covering on our nerves. And when that gets stripped off, it does not allow our nerves to function properly because it's lost its protection. So again, lots of different demyelination diseases that we have. Then, again, epilepsy and recurrent seizures, all different types of migraines. So again, you can see just tons and tons of different types of migraines, different headache symptoms, transient cerebral ischemic attacks. So transient cerebral ischemic attacks, they're like mini strokes that don't affect the body, meaning they don't leave lasting effects. And then we have vascular syndromes of cerebrovascular diseases. Sleep disorders, remember, are also in here. A lot of people forget that. Again, then we have different nerve disorders. So again, different parts of the nerve, the trigeminal nerves, the facial nerves, the cranial nerves, the different nerve roots all throughout the body, mononeuropathies of different limbs. Again, different types of neuropathies, polyneuropathies, we're going to find in this section. Again, other disorders of the myoneural junctions and muscles like myasthenia gravis, again, where we have a lack of strength in those parts of the body. Again, we're going to have, this is where we find the cerebral palsy, the hemiplegia hemiparesis, and the paraplegia, and the quadriplegia. And then again, as we go towards the end, we have disorders of the autonomic nervous system, things like hydrocephalus, and other disorders of the brain and central nervous system that doesn't seem to fit anywhere else. So when it comes to the nervous system, we have to remember, a lot of people forget, things like headaches and migraines are part of this. Alzheimer's is part of this. Parkinson's is part of this. All the different inflammation disorders of the different meningeal covers in the brain are all going to be in here. But the guidelines are really based upon the plegias and the pain. So always make sure you're getting the exact information. Okay, so that's what we want from our doctors. We want as much exact information as possible. So we're going to go to our next section of guidelines, which starts with H00 to H59. This is diseases of the eye and adnexa. So the first part of the H's are the eye, the second part of the H's are the ear. So all of our guidelines are based off of glaucoma and blindness. So for the glaucoma codes, before we even start the guidelines, this is what I want to talk about. So glaucoma, when we think of diseases, we usually think that the same disease is going to happen in duplicate organs. So if you get kidney disease in one kidney, you're going to get in another kidney. But that's not always what happens. The same thing with the eyes. You can have glaucoma in one eye, you can have glaucoma in both eyes. But here is where we have to be careful. There's many different types of glaucomas, and most of those glaucomas have stages to describe how much the patient can see. So when we're looking at glaucoma, what we're really looking for is documentation from the doctor about the type of glaucoma and the stage they have in both eyes. Because when we know that, we know whether or not we need one code to describe a bilateral glaucoma, which is the same type, same stage in both eyes, or do we need two different codes because the glaucomas are different stages or different types. So it tells us, assign as many codes from category H40 glaucoma as needed to identify the type of glaucoma, the affected eye, and the glaucoma stage. Okay, so when the patient has bilateral glaucoma and both eyes are documented as being the same type and stage, and there's a code for bilateral glaucoma, report only the code for the type of glaucoma, bilateral, with the 7th character for the stage. Okay, so if both eyes are exactly the same and there is a code for bilateral, one code, because the one code will describe the bilateral glaucoma with the stage. But when a patient has bilateral glaucoma and both eyes are documented as being the same type and stage, and the classification does not provide a code for bilateral glaucoma, which are in the subcategories of H40.10, H40.11, and H40.20, report only one code for the type of glaucoma with the appropriate 7th character for the stage. Now, it is up to the specialists who work with this area of medicine to decide how to help structure these codes. And for these code categories, H4010, H4011, and H4020, they have decided not to put bilateral codes here. So we have to be careful. One code, because remember, back at the beginning of your guidelines, it reminds us we can only use the same diagnosis code once per person. So even if they have bilateral glaucoma and we don't have a bilateral code, we can only use one code to describe it for those code categories. So be on the lookout. Those code categories you may want to highlight or star or make a notation in the tabular of your code book to remind yourself that they do not have a bilateral code that goes with it. But going on, when a patient has bilateral glaucoma and each eye is documented as having a different type or stage, and the classification distinguishes laterality, assign the appropriate code for each eye rather than the code for bilateral glaucoma. So again, different types or different stages, as long as there's a code for each one, just make sure you're matching up the right eye with the correct diagnosis of glaucoma and the left eye with the correct diagnosis of glaucoma. So again, we want to make sure that if they're different, we code for each one. But again, for those subcategories, when a patient has bilateral glaucoma and each eye is documented as having a different type, and classification does not distinguish laterality, again, H4010, H4011, and H4020, assign one code for each type of glaucoma with the appropriate seventh character for the stage. So again, those three code categories, make a notation so that you remember that if you get there, then you have to be careful about coding because they do not have bilateral codes. Now, when a patient has bilateral glaucoma and each eye is documented as having the same type but different stage and the classification does not distinguish laterality, assign the code for the type of glaucoma for each eye with the seventh character for the specific glaucoma stage documented for each eye. So again, same type, same stage, one code bilateral, unless it fits under those code categories, and then still one code. If they're different types, different stages, and we can use two different codes to describe it, we're going to do that. If we can't, with the H4010, H4011, H4020, one code. Again, we have to be careful. How is the doctor documenting their glaucoma? So we need to make sure that we're matching up the right eye diagnosis and the left eye diagnosis with the correct codes if they are not the same. Now, again, if a patient is admitted with glaucoma and the stage progresses during that admission, assign the code for the highest stage documented. So if the patient goes from stage 2 to stage 3, we only code stage 3 because that is where they ended up at the end of that admission. Now, we also have indeterminate and unspecified stages of glaucoma. The assignment of the seventh character of 4 for indeterminate stage should be based on the clinical documentation. The seventh character of 4 is used for glaucomas whose stage cannot be clinically determined. Okay, so again, when it comes to indeterminate, it means they can't tell. Maybe they can't tell because of inflammation. Maybe they can't tell because of traumatic accident or injury. So if they can't tell, we have an indeterminate. We cannot determine the stage. Versus the seventh character should not be confused with the seventh character of 0, unspecified, which should be used, which should be assigned when there is no documentation regarding the stage of glaucoma. Okay, unspecified is when we don't have enough information. Indeterminate stage is when we can't tell what stage the glaucoma is in. So again, documentation wording is important when it comes to glaucoma. The last section, and they've added this as new for this year, if blindness or low vision of both eyes is documented, but the visual impairment category is not documented, assign code H54.3, unqualified visual loss, both eyes. If blindness or low vision in one eye is documented, but the visual impairment category is not documented, assign a code from H54.6, unqualified visual loss, one eye. If blindness or visual loss is documented without information about whether one or both eyes are affected, assign code H54.7, unspecified visual loss. So blindness and low vision are being treated very similarly to glaucoma. What's happening with each eye? Okay, so if each eye is different, we code for each eye unless we don't have enough information, and then we have the H54.3, 56, and 57. So let's look at some of these H codes. So we're going to go back to ICD-10 data. Okay, so again, as we go from H00 to H5, now we're going to different parts of the eye. So we're going to see disorders of the eyelid, lacrimal system, and orbit first. So as we look at those code categories, again, we're going to see everything, the hortolums and chalazons, so different inflammations, other inflammations of the eyelids, disorders of the lacrimal system. So these are our tear ducts, disorders of the orbit, the eye bones. As we continue to go on, we have an entire area of conjunctivitis. Again, conjunctivitis, inflammation of the conjunctiva. Most commonly, the way that people get conjunctivitis is not washing their hands after they use the bathroom or touch something dirty and then rub their eye. And that bacteria then will lead to an inflammation of the conjunctiva. And then again, other disorders of the conjunctiva. We're going to see disorders of the sclera. We're going to see keratitis. So remember, the cornea, kerato, means cornea. So keratitis is inflammation of the cornea, corneal scars and opacities, then other disorders of the cornea. The iridocyclitis, remember, IRI is for the iris, the color of the eye. Other disorders of the iris and ciliary body. Remember, the ciliary body is basically what surrounds the iris on the inside. Then we go on and we start seeing things like age-related cataracts, other disordered lens, and cataracts and diseases classifiable elsewhere. H28 is used a lot to match with our diabetes codes, because cataracts are a general complication for those who are older, and especially a complication for those who are diabetic. Same thing with the retinal disorder. So we have the chorioretinal inflammations, other disorders, chorioretinal disorders, retinal detachments and breaks, retinal vascular occlusions. So again, what part of the eye? Always remember, what part of the eye are we in? Are we in the cornea? Are we in the iris? Are we in the retina? Where are we when they're describing these problems? So let's look at the H40s for a minute. Let's look more closely at these. So again, we have pre-glaucoma. Again, in general, and this is in general, you will notice that if something ends in a 1, it's for the right side of the body. If it ends in a 2, it's for the left side of the body. If it ends in a 3, it's for bilateral. In general, that doesn't go for the entire code book, but when we have these, you'll usually notice that 1 is right eye, 2 is left eye, 3 is bilateral. So again, we have pre-glaucoma. Again, we have open-angle glaucoma, low risk. Open-angle glaucoma with borderline findings, high risk. And as we go through, you can see all the different types that we're going to get. Now, again, you'll see here, now we're at H4010. Remember, these don't have it. These are the different stages. So if the patient has the open-angle glaucoma, whether it is unspecified or primary, again, we don't have bilateral codes for this, so we need to be careful what eye is doing what. All right, and then we go back to left eye, right eye, bilateral. Again, low tension glaucoma, pigmentary glaucoma, and again, under the H40s, you can see again, we have the stages here, mild, moderate, severe, indeterminate. Again, with capsular glaucoma, residual stage glaucomas, acute glaucomas, chronic glaucomas, intermittent glaucomas, so you name it. Again, there's a lot of different types of glaucomas here. What we need to be careful for, again, is what eye has what. And it's worth slowing down a little bit to make sure that you have the proper codes. All right, so a couple other code categories. Again, disorders of the vitreous body and disorders of the globe, because again, people tend to forget it's not just the actual separations of the eye, it's the whole eye itself can have different disorders. So where in the eye? We're also going to see issues with the optic nerve, again, like optic neuritis. And then again, we have different types of strabismus. So again, remember, strabismus is basically when the eyes are not facing forward when that child is born. So sometimes, most of the time, it's because one or more of the muscles is too short and the other side is too long. So I have a sibling who was born with both eyes crossed in, which is bilateral esotropia. Okay, you can also have exotropia where they face out, they could face up, they could face bottom. And so what they usually do is they go in and they'll perform surgery to fix the muscles of the eye. Remember, we have 5 muscles that hold the eye in place. And so they'll go in and do these as the child gets a little bit older. Then we have the visual disturbances, and we have blindness and low vision. So I just want to show you guys here again. This is what they mean by those categories, okay? So we have, we need to know blindness and low vision. Again, is it in one eye? Is it in both eyes? And do they give the categories for them? Okay, and so this is something that doctors have to do. Again, low vision is usually considered any vision with correction that is 20/200 or worse. Blindness usually is what we call NLP, no light perception. So again, how is the doctor describing the patient's vision? And then the last set of code categories, we're going to have nystagmus, which is the irregular eye movements, and then we have the intraoperative and post-procedural complications. So always remember that in general, the complications for each and every section tend to be at the end of these sections. So let's just kind of keep that in mind. That's always something to remember. Now, if we go back to our guidelines for a minute, what you will notice is there are no guidelines for H60 to H95, okay, for our hearing codes. So what we're going to do is we're going to look at them. So again, we have the diseases of the external ear, the middle ear and mastoid process, the inner ear, other disorders, and intraoperative post-procedural complications. So let's kind of go through these so we have an idea of what we're going to see. So again, we're going to see a lot of otitises, a lot of inflammations of the ear. So again, what's going on in what part of the ear? Then we're going to see, again, you see all the different types of otitis medias, because although otitis externa, which is in the external ear, can happen, otitis media in the middle ear is much more common. That's when the doctor looks inside your ear and tells you that your eardrum is red and inflamed. Most common, because a lot of times the bacteria likes to move further in the ear, but you can certainly have, an infection in the external ear. That's not a problem. We're also going to see things here dealing with the escutcheon tube. Again, remember the tube that connects the middle ear to the back of our throats. We're also going to see issues with the mastoid process, and we're also going to see issues with the tympanic membrane as well. As we keep going a little bit further, this is where we start seeing the otosclerosis. So we start seeing a hardening of the ear. So again, that usually leads to hearing impairment. And then we actually have the different types of hearing losses. So I want to show you guys this because it's similar to what we've been talking about with the glaucoma and the blindness. So again, we want to be as specific as possible with the insurance. So we need to know what type of hearing loss and in what ear. So for instance, if we have a child that does not have a right ear, okay, but they have a left ear, and the left ear is completely normal, but there's no right ear. That's what we call sensorineural hearing loss, because it means that there's no actual opening to go into the ear. So The way we would code this is the doctor would tell us it's sensorineural hearing loss, which it most likely would be if it's congenital. So we would go to our sensorineural hearing loss, and again, it would be unilateral right ear because they don't have a right ear with unrestricted hearing on the contralateral side, the opposite side. So again, we can describe what's going on during these situations, especially when we're talking about hearing testing and we're talking about possibly putting in things like ear tubes and stuff like that. We want to be clear with the insurance company what is having the problem. Okay, whether it's the eye or the ear, because again, you can have different issues. You can lose hearing in one ear, but have hearing in the other ear. But again, we're going to be looking for words like conductive, sensorineural, mixed conductive and sensorineural hearing loss. Okay, so we're going to be looking for all these different phrases so it can help us become a better coder. The other thing that we want to keep in mind is then we get to the other and unspecified hearing losses. So this is a complete hearing loss or sudden hearing losses. Okay, so again, we have like the deaf non-speaking, other specified hearing losses here as well. So again, we want to get as specific as possible based off of the documentation that we are given from our provider. The last set of code categories, again, is our intraoperative post-procedural complications and disorders of the ear and mastoid process. So again, just like the eye, even though there's no guidelines for the ear for hearing, we want to be on the lookout. Keep in mind, again, just because it's a bilateral organ does not mean it's going to have a bilateral problem, okay? So it's just like someone could have pneumonia in just one lung. The difference is that when it comes to pneumonia, they don't separate out the right lung versus the left lung and the lobes of the lung. But when it comes to eyes and ears, they do. So what we need to be careful for is what's happening on the right side, what's happening on the left side, and if it is exactly the same on both sides, whether it's an eye problem or an ear problem, make sure we get a bilateral code if there's a bilateral code available. If there's not, then one code to describe the condition. All right, guys, we will pick up in another chat talking about the I codes which go into our cardiovascular system.